In liver cancer, the elevated alpha-fetoprotein, serum elevated alpha-fetoprotein is both prognostic for poor outcome and currently is the only real biomarker to tell us which drug would work, which would be ramucirumab. With the other targeted agents, patients benefit whether they have a high AFP or not. But biomarkers with IO has been very elusive in all cancer types. In some PD-L1 expression has worked, but even in combination data, from my understanding in lung cancer, when you do chemo and PD-1, PD-1 directed therapies, you no longer need that biomarker. So the immune system is very complex, and I think the strategy in the liver cancer space has been single agent IO has a response rate of 15%, 15 to 20%, which has not been enough to improve survival in randomized studies like Nivo versus sorafenib or pembrolizumab versus placebo. But if we can just increase the response rate with a combination, then presumably now we're seeing improvements in survival. That's not to say that biomarkers aren't important, and there's still a strong effort to identify biomarkers, especially I think for the next generation of therapeutics, right? There's an interest in FGF19 amplification and linking that to response to FGFR4 inhibitors. But where that will play out in our treatment landscape is still to be determined. So I think we still need to try looking for biomarkers. Tissue acquisition is still pivotal. There's a lot of interesting studies that are really biomarker endpoints, meaning you get a biopsy at baseline, patients get treatment, and then you get some tissue at the time of surgery, and then you can do some very elegant biomarker work as well. And that will hopefully open up new avenues for drug development.